1, 2, check 1, 2. Boats and hose. You guys hear me on this? Anybody hear me? All right, guys, my presentation today is on bradycardia, a slow heart rhythm. And we'll just start off with a few parameters and get you all up to speed, whoever doesn't know. This rhythm that you see right here is called a sinus bradycardic rhythm. It's less than 60 beats per minute, and by definition, that's what we're going to refer to as bradycardic, a bradycardic rhythm. If anybody has any questions along the way, just speak up. There is going to be a P wave before each QRS complex. I wish I had a laser, but I don't. We have a PR interval, which the P wave.
Use the cursor.
Is there? Oh, perfect. Good idea. I got to see where I am. All right. Your P wave is going to be a little hump right here. A Q wave would be right here. R, S, and then this is your T wave. Okay. Your PR interval is going to start at the beginning of the P to right here, and that's going to be we measure that in big boxes and little boxes. The parameters that we use is 0.12 to 0.20 seconds. And I'm going to refer more in detail as we go. The QRS, the skinny little thing here, we want that at less than 0.12 seconds. Here's all the, can everybody see that? Is it too small? It's all right. Here are your parameters again, just in a little bit more detail. The PR interval, where my cursor is at the beginning of the P to the beginning of the Q. Just for a refresher for most of all of us, a big box, like where I'm pointing, is 0.2 seconds or 5 millimeters. And one little box, and there's 5 of these little boxes in one big box. A little box is 0.04 seconds. So when we're measuring out the PR interval, it's got to be less than 0.12. We also look at something called an ST segment for elevation or depression, signaling a possible heart attack. When you're treating somebody with bradycardia, we want to look for, does the patient look sick or not? Is the person look like an athlete? If somebody's an athlete, you got to, look at the picture of the patient, treat the patient, not the monitor. Just look for these clues. What's that? Just look at the a person and treat the person, not the monitor. Hence, treat the patient, not the monitor. Bradycardia can be caused by an increased vagal tone. And a vagal tone is, if somebody was bearing down quite a bit, taking a deuce or something, they could slow down their heart rate. Sleep. When you're sleeping, your heart rate comes way down. It could go below 60. Hypothermia, hypothyroidism, disease of the SA node, and drugs, digitalis, beta blockers, or quinidine, seizures. It could also be physiologic in trained athletes. So people like myself, a resting heart rate is about 50. So don't treat me if I'm sleeping. Here's an algorithm that we follow, that we memorize. All of us medics have seen this. Again, it's less than 60 beats per minute. How we're going to treat this is your ABCs. Give oxygen as needed. Do your typical control measures, your ABCs, your IVO2 and monitor. If you have adequate perfusion, just observe. If you have poor perfusion, if the patient it looks sick and their heart rate is below 60, we can give a drug called atropine at 0.5 milligram up to 3 milligrams. We have things, the heart can go into a block, an atrioventricular block or an AV block. It's an abnormality of the spread or flow of electrical activity from the upper chambers, the atria, to the lower heart chambers, the ventricles. This is a picture of a first-degree block. We're going to treat the patient, not the monitor. And typically for a first-degree block, we're just going to observe them. It's a delay in the signal that stimulates the ventricles to contract. Just reassess, and reassess. First-degree block is where the PR interval is a little bit prolonged. I'll move around a little bit, but there's a block called a second-degree block, type 1, and then you pronounce that winky block. It's irregular, and the way we can see that is varying PR intervals. There's a PQRST, and then it's going to get a little bit PQRST. There's going to be a little bit more of a delay, and then a little bit more of a delay, and then there's going to be a dropped QRS. We have another block called a second-degree heart block, type 2. It's more severe, it's more serious, and it typically won't respond to atropine, but it's possible. We'll try it, but it'll be a pacing style rhythm that we're going to want the pacing pads on. It's slow, but there's more P's and QRS's, but the big thing that we're looking for is the constant PR intervals to differentiate this block from a third-degree block. You can see the P, QRST, P. You have a drop QRS, but the P is here, and you're going to have a constant PR interval throughout, which signifies the type 2. A second-degree block is a partial or intermittent interruption of the signal that stimulates the ventricles to contract. A type 1 second-degree heart block called, another word for it is Mobitz type 1 heart block, or again, winky block. And the type 2 heart block is the Mobitz type 2. Just a little picture. Yeah, this guy's trying to slow down his heart rate. Again, treat the, what's that? Treat the patient, not the monitor. You're not just going to run up to him and, start pacing him. A little something, something. A little Bruce Lee action. Now here comes to the most serious of the blocks in relation to bradycardia. The P waves are everywhere. There's no relationship to the QRS, and there's no constant PR interval. It is a complete interruption of the signal that stimulates the heart to contract. Now you see, here's a P wave, QRS, P wave, P wave, QRS, P wave, P wave. This PR interval here is totally different than everything else. The P waves are marching through, and this rhythm here we're going to want to put the pacing pads on. And this is the conclusion of my presentation. Does anybody have any questions? Those are special dogs.
But are you pacing because it's Brady or because of the block?
Well, I kind of went from my original presentation, which is bradycardia, and then I threw in some blocks just to cover that part of it. But you treat them differently.
So you're pacing the Brady then?
I'm just pacing the second degree type 2.
If they're perfusing and they have a BP, you don't have to pace them. You put the pads on, which means most of the time I see these patients, they do have a blood pressure and they are perfusing, they're just kind of slow. So we keep the external pacer on until they go to the unit and then decide what they're going to do. A lot of times this is drug induced, these blocks. Frequently they're drug induced and they just wait and they resolve.
What do you guys pace out? What the rules?
We start low and just crank it up till we get captured, so it varies. Depends on the thickness of the chest and the pattern of the plate. That's usually what you do. You start low and you turn it up and watch the monitor until you see capture. Then you back it down until you lose capture and then you go back up until you get captured back. And that's what we're thinking.
Are there frequent the implantable pacemakers, or, around here? Are they pretty frequent?
You have to go through a whole process of evaluation before you can put a pacemaker in a patient. Otherwise, Medicare won't pay for it.
What do you got? Seems like everybody has it now.
Yeah, they're more commonly used because they recognize other etiologies.
Is this like a demand or what's?
They don't just use it for bradycardias and blocks, they use it for other things too. So. All right, good job. Make sure you give these to Greg. All you guys, when you do these presentations, give them to Greg so he can start a educational bank that you can go to when you want to look things up or when you want to, do a review of something. You can look it up in the agency's data bank. That way, you're not wasting your time doing these, forgetting about them.
No, do I need it? I'll just move my lips and. Mic check. All right, I'm going to do mine on capnography. I know I sent some of this out to you guys, I don't know, a couple months ago, but I figured I'd touch on it because I know nobody was going to read it. So capnography is used, it's tracking the patient's CO2 and their exhaled breath. You can evaluate their ventilatory status and indirectly their circulatory status and their metabolic status just by some of their numbers. Oxygenation versus ventilation, what's the difference? Good. Yeah, the oxygenation is O2 to the tissues, and ventilation is the movement of air, getting rid of that CO2, basically. Pulse ox is measuring oxygenation, and it's a delayed number, basically. And end-tidal CO2 is an immediate number, and that's measuring the CO2. Capnography, we can use it for a number of things. I'm just going to kind of go over some of these that I chose this one because I don't know if capnography was invented when I went to medic school. So no, it was used, but it wasn't used in the field. So this is one of those new pop-up tools that was given, and here you go. So I always kind of like read about it and see what I can find out. The more I can find out. So some of you guys, younger guys, it's just a normal medic school thing. So obviously the number one reason we use it to monitor ventilation. You can use the number itself, you can use the trends, but some of the numbers and the trends can, help warn you of things to come, which is a good thing. Hyperventilation and hypoventilation. What's hyperventilation going to do to your CO2 number? Did I hear decrease? Yeah. Anxiety, bronchospasms, embolus, decreased cardiac output, hypotensive patient, pulmonary edema, all that stuff can drop your CO2 number. And hypoventilation is going to raise it. Altered mental status, overdose, head trauma, stroke, sepsis, which we've never heard about. And somebody that's tired from CHF or a respiratory problem when they're done and they're about to go into respiratory arrest. The vitals and the trends can help you.
Jason, when you say trends, do you mean like the way the form it's taking?
Not the waveform itself, but the trends. And it's hard to set up on the monitor, but it gives you a bar every 30 seconds and the trends. And I tried to pull up a sample like trends because one of my examples needed the trends, but I couldn't get it off the thing I needed. But it can help you with your interventions. If you had somebody on a heroin overdose and you had two patients and you had one that was breathing 24 times a minute, you might just on initial assessment think that person's okay and do the rest of your stuff. And you could have another one who's breathing 8 times a minute, and that's the one you're going to jump on. But if you were actually put the numbers on them, you can have an overdose patient with 24 respirations a minute, and their end tidal could be 60, and the guy breathing 8 times a minute, his end tidal could be 35. So the guy with the 60 needs more help. Just as far as your overall, you can see he's breathing, but he might not be moving the air that he needs to move. So that'll help you, maybe intervene on that other patient a little sooner than you would have, being that you see that, because you're thinking that, heroin or whatever it is, an opiate, you're thinking that respiratory, you're going to jump on that lower one sooner. Paul, you all right? So stuff like that can help you with your intervention on your patients. Another way you can use it is to confirm tracheal intubation. But you always have to remember that once you intubate them, if their number's 0 or the CO2 is low, you have to remember that if they've had a long downtime or an embolism, it might take a minute to generate a number. And you also might need to, CPR might be necessary to generate a number. So you might have to, do a little bit of CPR before you can see a number on that. And don't forget, you can use an end tidal with a combi tube, LMA, or what's that thing that EMS uses? iGel. So you can use that too also to make sure that they're getting proper ventilation. You can use it during CPR. The person doing CPR, the rule is push hard, push fast, push deep. The person doing CPR, you can use that waveform and the number to make sure you're doing proper compressions and proper CPR. So it can, help you during that arrest or whatever you're doing. And also, if you're doing CPR, if the number shoots up, does anybody know what that indicates? Yes. So if that number jumps to 60 all of a sudden, stop CPR and check your pulses, because that return of circulation, you're washing out all the CO2 from all the tissues because of that circulation. So if that number jumps up, make sure you check your pulses. And same thing if you have on the other side, if you've brought somebody back and you're just monitoring them, if that number shoots down or it's on its way down, they might be, getting ready to arrest again or whatever it is was their problem. Sedated patients, not even completely out, just sedated enough to change their mental status. You can throw them on and watch that. This is the one I needed the graph for, because you can watch the trends on a sedated patient. Their heart rates really doesn't change much. Their pulse ox doesn't change a lot, but you can notice the trends of somebody has an impending respiratory event coming that's sedated. Their respiratory rate slowly drops, but if you notice their CO2, it's constantly rising. So if you see that, you're monitoring that, and he was whatever, they were 35 or 38, and every minute or two they're up a couple points. You might want to make sure you got everything in place, because they got something coming. They could have something coming. Asthma, COPD, and CHF, you can use it in those. Bronchospasms cause they call it a shark fin. And it's just a slope. Whoops. The shark fin, which we know the normal waveform looks like that. So the shark fin, that bronchospasm, it's, they're having a hard time getting that air out. So they're getting the air in, but they're having a hard time getting it out. So if you see that shark fin, it's going to be asthma patient, COPD patient. And mild asthma can drop their CO2 initially, and then as they progress through that event, they can go back to the normal range, and then severe asthma, they'll have a higher CO2. So you got to watch that in your asthma patients. And you can also, as you treat, you give them a albuterol, whatever it is you're giving them, you can get rid of this notch and take them back to a normal waveform. So you can also see your treatment working in their waveform. You can treat them and get rid of that shark fin. The CHF patient, the early CHF patient that has wheezes, and you might not be sure if it's COPD or CHF, if they have the wheezes and the history and the meds to go with it, but they have a normal waveform with the wheezes, then they're probably a CHF patient and not a COPD patient. So that's something to kind of take into account. A few other quick things. Monitoring their CO2 can help you keep you from hyperventilating a head injury. It can shock patients or potential shock patients. You can follow those trends and those numbers to see when they have a drop in cardiac output, so you know that they're progressing into shock. Hyperthermic patients, either from metabolic reasons or RSI, their CO2 is going to rise in a hyperthermic patient, which we could see here. And the other one, anaphylaxis from food, something I didn't think about until I read this. They can have their event, you can treat them, turn them around, but if the food's still in their stomach, they still have the allergen, so they can have a second reaction as they digest their food. And you're going to see the slope before you hear wheezes in that patient. So if they start having a second reaction to what's in their stomach still, if they ate a bunch of it or whatever it was, So you would see that before they actually started wheezing and having that event again. So that could, help you know what's coming, as long as you took a good history and you knew what was going on. So that's all I got on capnography.
Good job. Okay, so if anybody wants Jason's lecture, call him anytime of the day or night, 24/7. We'll get you in person. Here's a little draw.
My little, hey, I emailed it all to them, so they should have it.
Look it up on, on your library.
35 to 45.
Sounds like the single woman's mantra. Well, as long as they perceive it's deep, you're fine.
That's what hard and fast is for.
Okay, so what's going on with this projector over here? Well, for some reason, this won't come on here. Ugh, such a pain in the ass. Well, let's start with our case. Should show up, but it's not coming up.
Should try after.
This is a Mac, so it doesn't work like the other one.
No, great. We'll go F4 to.
Usually you do this, it comes up, but it's not coming up.
We use F4.
It doesn't do it.
Well, I could get Greg probably. Let me get Greg.
Anyway, what case are we up to? You have your books for homework? Number two. Somebody read the case.
72-year-old female collapsed in kitchen.
Oh, okay.
Stepping over zero, pulse 6, respiration 6.
All right, so you have a 72-year-old collapse. What was your BP? 70?
70 over zero,
Pulse?
26,
Respers?
6.
Okay, what was the first question?
Differential diagnosis.
All right, so what do we have?
Overdose. Stroke. Shock. Seizure.
With this, Greg, what you do is you're supposed to slide it, and it's supposed to come up down there, but. Oh, see, it comes up there. Well, because it's a Mac, it doesn't work like the way. I thought we had it